Hello, my name is James Charity. I'm a respiratory therapist here at the VA. As I address the board of directors, I want to thank you for listening to my presentation. If you don't recognize me, haven't seen me around the hospital, that's understandable. I've only been at this VA for less than a year, but I've been working in the VA healthcare system for about 5 years. A few months ago, I was handing out breathing treatments on the floor of the hospital and came across someone who didn't know how to use this inhaler. I played him a video that was available through UpToDate, and he made a remark to me that really stuck with me. He said, "No one ever showed me how to use this thing," talking about his MDI. So that's when I started to wonder, why didn't the COPD educator give this patient any instruction about using his inhaler? And that's when I discovered we don't have a COPD educator. Well, in order to help our veterans control their COPD, a COPD education program is essential. The four of us are involved with the COPD education program, and we're standing by to make sure that we can improve the quality of life for our veterans and also save the hospital a lot of money. The concept of starting a COPD education department here at the VA was mine, but it wouldn't have gotten off the ground without the assistance of Larry Guscope, who is an expert at smoking cessation, and Wanda Ring Eyes, who couldn't be here today because she had an eye appointment. And also please note that Miss San Diego will be assisting us as well. She was supposed to be here as well, but I couldn't find her. Now, just to briefly summarize COPD. COPD is the fourth most common cause of death in the United States, according to the Centers for Disease Control. People who suffer from COPD have chronic shortness of breath, increased production of sputum, and because they have a hard time breathing, they don't tolerate a lot of activity. COPD affects 1 in 17 Americans, and it's a disease for which there is no cure. But it can be treated, and every so often, somebody with COPD will experience an AE-COPD, or an acute exacerbation of COPD. An AE-COPD is something that will means a lot for the patient. While he's hospitalized, he has to take time off of work, he has to remove himself from his daily activities, and maybe worst of all, his lungs will experience remodeling. And that means that after a severe AE-COPD, his lungs may not return to the way they were before. As for the hospital, treating COPD is very costly. It costs between $15,000 and $20,000 per AE-COPD incident. Then there are losses in terms of bed space, in terms of labor, bed space and labor that could be devoted to other patients. Now I want to ask you something. Tell me a population category that smokes more cigarettes than almost any other. And we know that smoking cigarettes causes COPD. So what population category is this? Of course, we are the VA. We're talking about veterans. Before the dangers of smoking cigarettes were really well known, the U.S. military was freely and liberally distributing cigarettes to its service members. The old saying was, "Smoke 'em if you got 'em, and if you don't, pick up the butts." I served in the Navy, and it was basically expected that everyone smoked cigarettes. A couple of times while I was serving on the aircraft carrier, they would have to stop all smoking on the ship because they were unloading bombs. And let me tell you, that was a really unhappy crew trying to get by without their nicotine fix. Well, the real tragedy comes from Vietnam-era veterans. We drafted them into the war, gave them cigarettes, got them hooked, and then eventually they rotated to the civilian world, addicted to tobacco. Now, going into old age, they're still hooked on tobacco, suffering from COPD. And ladies and gentlemen, the federal government has a moral and ethical obligation to give them the very best care for their COPD, because we're the ones who got them hooked in the first place. From a business perspective, as you can see, COPD is a very costly disease to treat. According to the U.S. Census Bureau, the number of veterans in the Denver-Aurora metro area is 4,350. Now, I wasn't able to get exact numbers on admissions and readmissions for Rocky Mountain Regional. I tried, but I could not get very far. So I'm going to take a few liberties with the data. Let's say half of our COPD patients are admitted for a COPD exacerbation. Now, I know that half of them won't get AE-COPD, but this is including readmissions. There is a New England Journal study that shows that 20% of COPD patients are readmitted within 30 days and 33% are readmitted within 90 days. So this number includes admissions and readmissions. Now, according to Healthmonics, an AE COPD admission costs about $20,000 per incident, and that makes a total cost of $45.5 million annually. So what's the solution to this problem? What we need to do is start a COPD education program and a 24/7 COPD clinic. Together, these additions to our COPD patient care will not only improve patient care and quality of life, but will also save the hospital millions of dollars. This is a 3-part program designed to bring down COPD admissions and readmissions. The first step is to educate a COPD inpatient educator. This educator would go into the patient's room while they're admitted and give the patient training. How to use his MDI. What is the disease process of COPD? And not only that, but the educator will also go through the chart to make sure the diagnosis is correct and PFTs are up to date. There have been documented occurrences where someone has been diagnosed with COPD and treated for COPD when actually they have some other problem like heart failure or pulmonary fibrosis or some other lung disease. Step 2 is an outpatient COPD educator. This educator will call patients at home to make sure that they're managing their disease well. They might rarely have to drive to their house. If that's what it takes, then that's what we'll do. They might also help a patient go through a COPD exacerbation, talk them through it over the phone. And lastly, they'll coordinate with the O2 supplier to make sure that their O2 demands are being met. They can also advise patients on going to the COPD clinic, which I'll describe in just a little bit. Now, there is an army of studies out there talking about improved interaction between patients and healthcare providers will improve patients' control of their COPD symptoms. There's also a lot of evidence that patients will not use their inhalers correctly, and that is a mainstay for COPD care. Our COPD educators would make sure that veterans were taught the importance of MDI use and correct technique. The inpatient educator would meet each one in the hospital, while the outpatient educator would call them at home to make sure that their symptoms are under control. Now, the third part of my 3-part proposal is setting up an outpatient COPD clinic. Imagine for a minute it's 1 o'clock in the morning and your breathing is getting worse and worse. You thought this breathing episode would be something you could handle, but in the last few hours it's gotten worse and worse. You're coughing up lots of thick, purulent, yellow and green sputum, yuck, and you just don't know what to do. Would you call your doctor? Well, unfortunately, the doctor's office closed at 5 o'clock and won't open up until Monday. And now here it is, 1 o'clock in the morning on a Saturday, and you realize you're not going to be able to make it until Monday. Sounds like a trip to the ER and an admission to the hospital, right? Well, no, not if we have a COPD outpatient clinic. Patients can go to the clinic anytime they need to, and they don't need to make an appointment. There at the clinic, they'll get the nebulizer they need, they'll get a bedside spirometer, and an assessment from a respiratory therapist. Maybe even a BiPAP machine if they're not getting better, and if they need admission to the hospital, the professionals at the outpatient clinic will call them an ambulance to take them over to the hospital. They'll be admitted through the ER, or they'll be taken to a wing of the hospital for observation. It's not an admission. They're there for observation, free to come and go as they please, with a nurse checking on them every so often. That's how we decrease admissions and readmissions. We're there for the patient all the time. And here's a few studies I wanted to show you. This one on top by Riley and Skurba talk about what a patient with mild to moderate COPD requires, which requires, and sometimes they require things that they can't have at home. This middle study talks about outpatient clinics that they have in Spain, and this last one here talks about COPD readmissions. If we give COPD patients somewhere to go besides the hospital, they will use it. It's better for them, and it's better for us. Where would we put the COPD clinic? Well, this is where I'm suggesting. It's right across the street from the hospital. The place I'm proposing, you've probably driven by it 100 times. It's that Fitzsimmons apartment complex in that same shopping center as where IHOP is. It's just south of the hospital. It's right across the street. Easy access from the street, plenty of parking. There's a bus stop and a light rail station nearby. And perhaps most importantly, if someone in the clinic is not doing well, it's a short ride by ambulance to the ER, right around the corner. And I'll get to the rent and the cost in just a little bit. Okay. This is a layout of how the chain of command would function in the new department. Because the COPD educator deals with, the education manager deals with both inpatient and outpatient managers, he'd have to coordinate a lot with the inpatient and outpatient managers. Coordination with the outpatient manager would be essential because there's bound to be a lot of veterans whose PFTs are out of date, and we'll also have to communicate a lot with the inpatient manager to discuss the best approach for treating COPD on a patient who is difficult to manage. Also, if the outpatient manager is overwhelmed at night, they may have to call an inpatient therapist for help. This chart here is a timeline of when we can get this project going. For simplicity's sake, I made it as though the program were starting on January 1st of this year. And this is only half my timeline. The other half is coming right up. As you can see, the timeline takes us up to when we interview patients on February 22nd. And here's the other half, and this shows that we could get the program up and running by the 4th of July of 2021. The sooner we get this program going, the sooner we can enjoy the benefits, both we as business, institution, and as healthcare providers who want to see our veterans live happier and healthier lives. Now let's talk about cost. The cost to remodel the clinic across the street at Fitzsimmons Apartments. Now I know the text is small. If you want a copy, then I'll be happy to email it to you. But the bottom line is about $150,000 to remodel the clinic. Okay. Now here's my estimate for an annual cost. And again, the text is small. I'll email it to you if you want. But the bottom line, $375,000 annually is what it would cost to run a COPD education department. Now, remember at the beginning of my lecture, I said that we would spend about $45.5 million to treat COPD. If this department were to simply prevent 9 COPD admissions or readmissions, then the department would pay for itself. That's not good enough, though. Our goal would be to reduce admissions and readmissions by 20%. That would cut that $45.5 million price tag down to $36.4 million, a savings of $9.1 million per year. Okay, so wrapping it up, COPD is a disease for which there's no cure. We have more veterans suffering from COPD than other non-veteran Americans. It's a very costly disease, but we have to treat it. And the best way to reduce costs associated with COPD is through a COPD education program and an accompanying outpatient clinic that's open 24 hours a day, 7 days a week. If we do this, the annual cost would be around $375,000, but those costs would be offset by the savings, which would possibly mount up as much as $9.1 million saved every year. All right, and that's the end of my presentation. Thank you for your attention. If you have any questions, please feel free to call or email me. Those are my numbers, my number there, and my email address. And here are my references. Thank you very much for listening.